Welcome to Medicaid Matters, the only live talk show about the business of Medicaid health care. And now, here's the host of Medicaid Matters, Richard Yadon.
And thank you, Braley. Hello, everyone. We're very glad that you've decided to be with us here for the next hour. It will be an hour filled with information and insight that you can use today. And this is what our listeners keep telling us they like the most about Medicaid Matters. Our topics and our guests are relevant, they're timely, and they're practical, and that's what we like to hear. That's what we set out to do with Medicaid Matters, and we're glad that you're being a part of our broadcast today. You know, something else our listeners enjoy is the interactive character of our show. We don't provide lectures. This is not about training. But we give you an interactive conversation with Medicaid's most influential personalities and thought leaders in the business today. And certainly today is no exception, as we will shortly be joined by Dr. Patricia Hines and Dr. Bonnie Barnt-Maglio, both senior consultants with the Camden Group. And we're going to talk about a subject that is high on the priority list of every single Medicaid organization: reducing hospital readmissions. Our guest recently co-authored a paper about strategies to reduce readmissions, and the paper summarized their research and their experience in this area. So Dr. Hines and Dr. Barnt-Maglio will be with us in just a few minutes. Well, this is such a hot topic. I have heard this over and over again from our clients. I've heard it over and over again in conferences that we've been to. I think you'll probably want to join in the conversation. So do you have a question? Do you have an experience that you'd like to share? And if so, there are multiple ways that you can join us today. You know, the most effective way probably is just to give us a call. 626-657-2125. Again, that's 626-657-2125. Give us a call, and you can talk directly with me and our guests right here during the show today. You can also tweet a question to us if you are logged into your Twitter account. Our handle is @MedicaidTalk. And if you're on Skype, Medicaid Talk is also the name. You can talk with us right online in that medium as well. Well, strategies for reducing hospital readmissions. That's going to be our topic of conversation here for the next hour. It's also a topic we keep hearing about a lot in Medicaid today. It's a key component to not just cost containment initiatives, but it's also a key component to most care management plans and to improving the overall quality of care for the Medicaid population. It's getting a lot of attention these days, and we are excited to have two guests with us that have developed some intriguing insights to this problem and some ways that it can be addressed. So joining us will be, again, Dr. Patricia Hines and Dr. Bonnie Barnt-Maglio, both with the Camden Group. The Camden Group is a healthcare business advisory and consulting company. They have offices in Chicago, Los Angeles, and in New York. Dr. Hines is a vice president at the Camden Group and a clinical and operations expert with a strong nursing services background. Her focus includes nursing practice and operations, case management, critical care, patient throughput, and joint commission preparation. Before joining the Camden Group, Dr. Hines served in senior positions at SG2 Healthcare Intelligence, Cardinal Health, APM Management, Good Shepherd Medical Center in Illinois, and Rush Presbyterian St. Luke's Medical Center in Chicago. Dr. Hines is also a member of the American College of Healthcare Executives, the American Organization of Nurse Executives, the Association of California Nurse Leaders, Case Management Society of America, and the American Association of Critical Care Nurses. She is an accredited case manager and a published author. And also with us is Dr. Barnt-Maglio. She is also vice president with the Camden Group with over 30 years of experience in the healthcare industry. She has extensive expertise in the delivery of patient care, resource management, operations, and planning. Dr. Barnt-Maglio also has a strong clinical and operations background, having held administrative and clinical positions in several healthcare organizations, including community and specialty hospitals as well as academic and medical centers. So Doctors Hines and Barnt-Maglio, we want to thank you very much for being with us today. Did I miss anything in the introductions?
No, I think you were very thorough. Thank you.
Okay, great. Well, before we jump into our subject today, we should mention to our listeners that the Camden Group is not a Medicaid-specific organization, although that is an area that you touch on a lot. Let's start maybe with you, Patricia. Could you give us a high-level overview of your organization and how your work might relate to the Medicaid audience?
Absolutely. Within our practice, we have 4 major product or service offerings. The first is around strategic and business planning, where we're helping organizations with bundled payments and clinical integrations that would affect all patient populations. Our second is financial advisory and compliance, and there we might do things like valuations and fairness opinions as for organizations. The third area is physician group advisory services, and we have several physicians in our practice that assist us with hospitalist programs and assist us with working with accountable care organizations and helping organizations readiness for that. And then the last is hospital operations, which Bonnie and I work in, and we do a lot of work with care management, patient throughput, performance improvement. And many of our hospitals are actually safety net hospitals. So a pretty broad perspective of different organizations we work in and different practices all related to health care.
Well, that is I'm certainly getting your perspective from your expertise in hospital operations, and the work that you're doing there is going to be very insightful for our audience, I know. Bonnie, both of you recently co-authored an article about reducing hospital readmissions. What prompted you to write this article?
We wrote this article in response to what we're seeing with our patient populations. We do a lot of work with throughput, and particularly in emergency rooms. And what we found is that many patients are coming back to the emergency rooms after being discharged such a short period of time before. Our research has indicated that only about 15% of patients see a primary care physician within 14 days of discharge. So if that hospital stay was complex or the patient was discharged without proper teaching or is not able to manage their care, they end up in the emergency room. And that was what really piqued Patty and my interest in readmissions, and along with the penalty that CMS is implementing in the next year.
You know, I would also say that in the times that Bonnie and I spend in hospitals, as we're talking to administrators and physicians and caregivers, they themselves can articulate the fragmented systems of care and the challenges they have in moving patients through the continuum and the frustration when they see their patients returning. And we began to think also about what that experience was like for the patient. Being admitted to a hospital is a very frightening experience. Our systems can be very complex, and the whole notion of having to be readmitted then really causes stress and anxiety for the patient and for their families.
Mm-hmm. Yeah, no question. And when you mentioned 15%, only 15% see a primary care physician after discharge? Is that what you were saying?
Within 14 days of discharge, yes.
And that's 15% of all patients, not just Medicaid patients.
That was a study from Dartmouth Atlas that talked about Medicaid patients,
okay.
Medicare patients. But when you look across the statistics that are being kept, it's even lower. It's believed to be even lower for Medicaid patients.
Yeah.
So the continuum of care is interrupted, right? Usually when the patient leaves that parking lot of the hospital, as far as follow-up and support and the kind of mechanisms that would help a patient remain in their home and cared for appropriately and get well rather than have to become a patient again in the hospital.
Mm-hmm. So as a consequence, they don't necessarily get well because they don't have the follow-up, and then they show up again.
Correct.
Well, that's a cycle that we've heard a lot about in Medicaid, no question, and it's a real issue. Now, you mentioned, and I wanted to touch on this as well. You mentioned that this has been a focus of CMS as well. Could you maybe explain that a little bit more about what their focus has been, and then kind of where that is headed over the next year or so?
Certainly, CMS has identified pneumonia and heart failure as two diagnoses that they're going to be tracking, that they are tracking now in 2012. If the readmission rate for these diagnoses over the next year is higher than expected, the organization, the hospital, will receive a 1% penalty, reduction of reimbursement penalty across all Medicare admissions. That's the first year in 2013 they'll receive that penalty. It won't just be for the patients that bear that diagnosis of heart failure or diabetes. It will be across all reimbursement. In 2014, that will go up to 2%, and in 2015, it will go up to 3%. And the idea is to really encourage hospitals strongly to work with patients within the hospital and then without the hospital to extend their continuum of responsibility to decrease readmissions and just to discharge and care for healthier patients.
Mm-hmm. It would seem that they're going to have to work perhaps even more closely with managed care organizations that are providing care management services, wouldn't you think?
Yes, absolutely. They are working with managed care organizations, but the original penalty will be with Medicare patients. And so that is where the penalty lies, and that will force organizations, hospitals, to focus on not just post-discharge care, but even preventing admissions in the first place.
Are you hearing? Go ahead. I'm sorry, Patty. Go ahead.
Readmissions alone costing about $26 billion in a decade. I think CMS has taken this initiative, but the more other health providers are going to follow suit. And it's just incumbent upon all organizations to really think about what the rising health care costs are and what strategies we have in place to really focus on improving quality, and as a result then controlling our costs and controlling our readmissions for our patients.
Do you see any movement with this penalty being extended to Medicaid, or maybe states thinking about doing this with Medicaid?
Well, we certainly know that adult Medicaid patients under age 65 have very high readmission rates, 50% higher than those of privately insured patients. And the adults around age 45 to 64, they're rehospitalized about 60% more frequently than uninsured patients. Mm-hmm. So I think this is just incumbent upon us all to think through not only the Medicaid population, but all populations, and focusing on those diagnoses and conditions that are really the where we can yield the greatest opportunity for our patients, such as heart failure, pneumonias, post-cardiac surgeries.
Do you think this is a bigger problem with government-sponsored health plan beneficiaries or with commercial beneficiaries?
Our sense is that it's been more of an issue with government-sponsored beneficiaries. You have to remember that commercial programs and insurance companies really are risk-based organizations, and they are also worried about a profit line. So they are much more apt to have contact with their patients, be able to reach them through their employer, be able to reach them directly and direct their care in a way that is preventative. We know that many commercial payers will, for people, for example, with asthma or heart failure or any of those kind of diagnoses, will be in touch with them ahead of time. If they don't fill their prescriptions on time, they'll get a call. If they've had a procedure, they'll get a call at home within a couple days of the procedure, a following week, whatever specific intervals as well as what it requires from the patient's health to make sure that they're getting the appropriate referrals and care that they need. That's not necessarily the experience with the government-sponsored programs.
Okay, well, we're going to take just a very short break here, about 2 minutes, and then we're going to hear more from our guests, Dr. Patricia Hines and Dr. Bonnie Barnt-Maglio. So stay with us, and we'll be right back. And welcome back to Medicaid Matters. This is the only live and interactive talk show about the business of Medicaid. There is a tremendous amount of movement today in Medicaid. There's a tremendous amount of change going on, and some of these changes could put you in a position to rapidly advance your career. MedicaidJobs.net can help you get there faster. It's not just traditional jobs, though, that are developing today. For instance, our firm has just partnered in the last week with 2 clients that are expanding. There's a huge need for nurses, both RNs and LPNs, in Ohio, and for nurse practitioners in Tennessee, Wisconsin, and Virginia. You can get more details at managedmedicaidservices.com or just click on the opportunities page. Go there today and see what you might be missing. We're talking with Dr. Patricia Hines and Dr. Bonnie Barnt-Maglio about strategies to reduce hospital readmissions. And when we were talking there before the break, we were talking about the focus that CMS has, primarily looking at 2 conditions, pneumonia and heart failure. But I wanted to ask you, maybe Patricia, you could take this one first. Is there anything, a specific condition or circumstances beyond those that seem to be driving higher readmission rates?
Absolutely. We know that in the patients that have medical conditions, the sort of top 5, if you will, heart failure is clearly highest in terms of readmissions. We also see patients with COPD and pneumonia, and we see patients with psychosis, and then also patients with GI problems. And when I think about the COPD and pneumonia patient population, so often those are patients that would really benefit from the transition from acute care to their home through the venue of home health services. Or we see the patients with heart failure and the confusion about whether the patient's care is going to be provided by the cardiologist or by the internal medicine physician. From a perspective of surgical patients, I think we're seeing a fair amount in vascular surgeries, but we're also seeing some patients with orthopedic, like fractures of hips and femurs or major bowel surgeries. And again, I think the question is, how are we transitioning that care to the next venue? And is the surgeon thinking he or she will follow up with that patient, or is it going to be the primary care provider? Is the patient taught about how to watch for wound care, et cetera? So we do understand that there are certain conditions that have the highest rates of 30-day readmissions, and that's certainly an area for organizations to start to focus on.
Those seem like heart failure, COPD, pneumonia, GI problems, and that. Those are typically conditions that are associated with older adults. Maybe you could break down the issue into different categories to help our listeners understand the scope of the problem. For instance, what does this issue look like demographically?
Well, we are certainly seeing that those patients that are at higher risk have multiple comorbidities. They may not have the support systems in place that from either caregivers, son or daughter across the country. We see patients that have language issues, literacy issues, even cultural issues. And, I can give you a perfect example of a family member of mine who is elder and is vacationing in Florida and started to have some cardiac irregularities. Was seen in the hospital, emergency department, sent back home, put on a Holter monitor to monitor his arrhythmias, and then sent back in a few days later because he needed a pacemaker. And so I talked to this patient's spouse the day after he was discharged, and she was questioning what kind of medicine should he be taking. And I said, why don't you get the list of patients' discharge instructions and read them to me? And as she was reading those to me, it was very clear that we weren't really thinking about how to care for this patient in that transition. One of the discharge orders was not to raise the LUE, and we as clinicians know that's a left upper extremity, but a patient doesn't know what that is.
I was going to ask you to explain.
So those are the kind of the communication issues we have to think about. We have to talk to our patients in a manner that they can understand and can hear, and repeat back to us so we know that there's been that comprehension. So that's all about dealing with the comorbidities, dealing with the language, making sure you've got the right caregiver there, and making certain they understand what needs to happen.
What does what does it look like geographically? Is it more prevalent? Is the issue more prevalent in some parts of the country than others?
Actually, yes. It's more prevalent within the Midwest and eastern part of the United States than it is in the West. Mm-hmm. States like Kentucky, Tennessee, they have a much higher rate, usually about 20%, as much as 20% readmission, compared to states such as Nevada, California, and the upper Midwest, such as Nebraska, Montana, areas like that. We see the highest area really is, as I said, Kentucky, Tennessee, Indiana, states in that swatch. Also upstate New York, and places in Michigan. A lot of it follows, to a certain extent, the socioeconomic climate that has been challenging for all of us for the last 3 or 4 years.
Mm-hmm. Yeah, it's and those states aren't necessarily high density population type of states either. You would think if it was just a matter of more people and the situation occurring, it would be in states where the population density is there. So there's certainly much more going on than just they have more people than other states. Well, maybe you could maybe there's some other ways you could potentially categorize the issue of high readmissions. I mean, if our audience wants to kind of get their arms around and say, all right, what is the profile of, or what are the 3 or 4 characteristics of a patient who's going to potentially have a risk of higher than the normal readmissions? What would that look like?
I'll respond to that first, and I know Patty has her ideas as well. What we typically see is a patient that is of lower socioeconomic level, a patient that has multiple comorbidities, such as diabetes would be a major player in this, patients that have limited family support, and patients that need more education and more support within the community. We often see these patients that use a safety net hospital to receive their care for their admission. And then when they go back out in the community, you have to remember that issues such as diabetes, heart disease, or pulmonary disease, lung disease, are patients that in their everyday life have to consider what their diet is going to be, making good decisions with regard to, let's say, sodium intake, and make good decisions with regard to their budget. Some patients do not understand the impact of their medications and will choose to spend their money on something other than medication, maybe even food. Mm-hmm. They don't understand also the importance of keeping a regime, and there's not enough reinforcement of that to keep their health an optimal status. There was an interesting article in the Washington Post a couple months ago about a patient who was discharged with diabetes and cardiac disease, and his understanding of how to make reasonable food choices based on his disease level, and how difficult that was for him, because it's an everyday, 3 times a day at least, situation for him where he has to make good choices, and he just really didn't understand.
And I think we also need to think as patients even enter the emergency department, which of those patients are at high risk. We know that if patients have had 2 or 3 visits to the emergency department in the previous 6 months prior to being admitted, they're at a high risk for readmissions. We know if they've had more than several hospitalizations in the last year, they're at a high risk for readmissions. And so we need to think about how to stratify those patients to a low, medium, or high risk, and how to apply our resources appropriately so we're going to realize the greatest yield for those patients that have the highest risk for readmission. And, Bonnie was absolutely right in terms of the demographics, the comorbidities, but I think we also are looking at the number of different medications the patients have had, as well as the patient's readiness to change around their behavior modification.
Patricia, do you see more hospitals starting to screen for this in a systematic way?
I believe the hospitals that really do the best are when there's an emergency department case manager that's working closely with the medical staff and really able to think about the number of visits, what the care was like prior to coming to the emergency department, and working with the primary care providers in the communities to understand where the patient is best served in the hospital or back into the community and their care there. So I do see a trend in terms of placing case managers in the emergency department to assist with that high-risk assessment.
Mm-hmm. And I've had personal experience with that, with being my wife being a primary caregiver in many respects for her father. Whenever we've had to get him to the hospital in the emergency room, we've met the ambulance there, and oftentimes there was a case manager already there asking us questions and so forth. That was very impressive and a very smart way to do it.
Absolutely.
Well, in your article, you talk about patient and hospital readmission risk. I think I understand the patient side of it. Tell us a little bit about what you mean by hospital readmission risk.
Well, certainly the organizations are doing an awful lot to understand what their quality and operational metrics are. So they're taking a look at their patient satisfaction scores, whether it's something like a Press Ganey or it's their HCAP scores, and they're trying to understand where they're at in relation to where they've been over time. They are monitoring their core measures for heart failure, for acute MI, pneumonia. So it's very important that they're taking a look at those. They're also looking at the utilization of resources and how are we applying those resources within the hospital. So, for example, are all patients placed on a telemetry unit, or are we using select criteria to place a patient on a telemetry unit? And then what does that mean then in terms of their cost per case? And then following their readmission metrics and understanding what their readmission rate is and how that compares to their state-level readmission rates, so they can profile themselves and look at how they're doing against best practice, how they're doing against themselves, and how they're doing against their organization's goals. And by taking a look at those risk assessments, they're really able to define what strategies are appropriate for them to design and to implement across their systems.
Patricia, anything?
I would agree with Patty, and there's also a better understanding that when a high-risk patient, a patient that's highly likely to be readmitted, enters the hospital, it's really that represents a risk for that hospital, for their reimbursement in the future, for their ability to continue to be considered a high-quality provider by CMS. So there's more and more understanding that the hospital must tie themselves to this patient and focus on what is it that they need to be cared for within the hospital, mm-hmm. and then within the community in order not to be readmitted. And that means some of the clients I'm working with include the hospital advice line is back, places that patients can call and ask for advice and discuss some of their symptoms. Increase in home health programs where a nurse will come to visit, and also telehealth, the ability to communicate with patients from their home, either via computer or even text messaging or some kind of electronic medium where there's a stronger link of communication with them once they leave the hospital.
Mm-hmm. And we're seeing that in our Medicaid clients, a lot of lot of movement into those areas and a lot of innovation going on with that. We're going to have to pause here for just a couple of minutes, and when we come back, I want to talk a little bit more about the article that you wrote and what was in that. If you have not, as a listener, joined our community on Facebook, Medicaid Talk fan page allows you to connect there with other Medicaid professionals to get timely updates. Make sure you go and like it today. Stay with us. We've got a lot more to come. Well, let's get back to our two experts from the Camden Group, Dr. Patricia Hines and Dr. Bonnie Barnt-Maglio. And we also have some questions coming in from some of our listeners, and we're going to get to those as well. But let's talk a little bit about the article that you both wrote here recently. As you know, this is an issue that is very, very close to our audience, very close to the Medicaid population. Maybe you could tell us what some of your research revealed about the readmission risk in the Medicaid population. If there are, certain. I know we talked about this in a broad sense a little bit earlier, but if you were to dig it down to the Medicaid population, are there any characteristics just very specific to that population that would increase the risk of readmission?
Well, within the Medicaid population, for those, say, aged 18 to 44, we know that as time progresses from 7 days to 14 days to 30 days, there is an incremental increase of the readmission rates, as well as for those that are older patients. And what we're finding is that for many patients who are readmitted within 30 days, they have not seen a primary care provider. So that patient population may be using the emergency department as their primary care provider. They may be using clinics or elsewhere where their visits and their monitoring and management of chronic diseases is not well coordinated. And so the whole notion of having a primary care provider and managing that transition from the hospital to the home setting is really the most important, and getting them back in front of a primary care provider so they understand and they're following through with medications and with their treatment regimes, and they understand when to contact their provider.
Mm-hmm. You've mentioned this several times, how important this primary care provider is in the interaction, the ongoing interaction, particularly post-discharge with the person. Do you think some of these, some things like accountable care organizations or patient-centered medical homes, do you see these as potentially being a way to alleviate this problem of readmission risk?
What we're really seeing is the management of the transition from the acute care to the home care, and how do we educate our patients so that they can become more partners in care with us, and how they can really be engaged in their plans of care. So a lot of our focus has been with organizations understanding what strategies are best from the management from acute care to post-acute care back into their home environment, and what the role of the physician is, whether it's a primary care provider in an independent practice, whether it's part of a medical home practice, but really linking them back with the primary care provider.
In the article, you cited a number of initiatives and a number of ways that organizations can take to address this. One of them was communications as a solution, and we've kind of touched on that in our conversation up to this point. What kinds of communications should hospitals be engaging in that would be most helpful in reducing readmission risks?
Well, we certainly see that as you're managing the patient through the continuum of care, the communication is very important. So let's think about a patient that's being cared for in a primary care provider's office. They end up going to the emergency room, so they see a second physician there in the emergency department. They end up getting admitted. They may be admitted to a hospitalist program, so they've got a third physician there. On discharge, they are going back to the primary care provider. So you've got 4 different individuals that are touching that patient through that continuum of care. And the question to ask is, how are we managing all those handoffs and all of those communication strategies from each of the different providers across that continuum? And the answer is not always that well. And so I think as we focus on the different strategies to formalize those handoffs, we need to think of both verbal as well as electronic communication strategies.
One of the areas that healthcare has really fallen down on is electronic communication and an integrated record. A patient may go into the emergency room, and that physician does not necessarily have access to the visit that he had with the primary care provider maybe the day before, 2 days before. So creating those types of communication handoffs, that kind of central record is really essential if we're going to be able to decrease the readmissions for these patients.
One of our listeners is asking, what hospital systems do you think are doing well in reducing the readmission risks?
There was an article that was published not long ago, and I believe it came from the Commonwealth Fund, and they actually did a little bit of a survey in terms of a couple of different hospitals that they studied. And one of them was St. John's Regional Health Center in Springfield, Missouri, and another one was Memorial Hermann in Houston, Texas. And the reasons that they cited for the ability of the readmission case studies is because in heart attack, heart failure, and pneumonia, they were all able to reduce their readmission rates below the national averages. And the variety of different strategies that they used are some of what Bonnie and I spoke of in the article that we wrote, and really thinking again about the discharge planning process, and that needs to begin on the patient's first day of stay as opposed to on the last day of stay. So really starting to assess the risk factors, starting the education, starting the communication, making certain that you're including both the patient and the care provider. So that early discharge planning was very important. They also saw patient engagement as very important, making certain that the patient understood their diet, their activities, their medications, and were understanding the rationale for compliance so that if there needed to be behavior changes, there was good rationale for that. Thinking about medication management, that's a huge issue for patients when we bring them into a hospital and we adjust their medications and don't have a really good reconciliation process in place so that they know when they go home they take what medication for what reason, how often they take it, if it's in the morning, at lunch, or in the evening before they go to bed. So those are a couple of examples of where these organizations have really initiated a lot of efforts to manage some of that best practice. And Bonnie, I don't know if you've seen any others or read of any others.
Yes. Some of the hospitals in New York, NYU Medical Center is one. Another one is University of Texas Health Branches is also doing some work. We work a bit with University Healthcare Consortium, and what we are hearing from them is that a number of university health systems are working in a different way to address this problem. They are identifying patients in their clinics that they feel they can have a big impact on and managing them before they even get to the admission phase. So that's another way to address this problem, is to work within your system, your clinical areas, your outpatient areas, to address the issues before and prevent any admission in the first place.
Well, and that leads me to the next question I wanted to ask you about, the next area I wanted to ask you about, which is if you have found in your research and your work any certain types of interventions that seem to have a real significant impact on reducing readmission rates.
The one that I think has a lot of implications are medication reconciliation and making certain that when we've adjusted the patient's medications and their hospitalization, they know what they're taking when they go home. And I've even seen organizations that are identifying their Medicare, Medicaid patients that have high risk for readmission and actually sending a pharmacist out to the home within 24 hours to make sure, number one, that the patient has had all their prescriptions filled, that they know how to take them, they know when to take them and why to take them, what side effects they may have, and when they need to contact their physician. So medication reconciliation, I think, is very important at discharge and then ensuring compliance. And then again, when the patient goes back to the primary care provider for the initial visit post-discharge, bringing those medications with them and also reviewing again how those medications have been used.
Bonnie, anything?
Another method that's beginning to be used is based on the principle that there are actually more cell phones in the United States than there are people. And so using text messaging from the primary physician or the discharging clinic to communicate with patients, get an update how they're doing, checking in with them that way, using other kind of social media in order to keep in constant contact with them. So once they do go home, if they have a question or if they're confused or if they just need some information, they have a variety of ways of accessing that easily without calling a clinic and being put on hold or waiting for an appointment or any of the other kind of delays we often see in our healthcare system.
There are more cell phones in the U.S. than there are people. Is that what I understood you to say?
Yes, there's about 350 million cell phones, the latest statistic that I read, and there's only about 325 million people in the United States. So there is a really wonderful example of using the electronic medium in a clinic in Nuka, Alaska, that has a high Medicaid population, and they have enlisted formatted themselves into teams that include a pharmacist, a physician, a nurse practitioner, a social work, and nutritionist. And they have organized themselves into 4 teams and assigned a panel of patients to each team. And their first goal is that when a patient calls in, that there is some professional that speaks with them immediately. So it does not necessarily have to be the physician. It can be the nutritionist or the social worker, just to get an idea of what that patient's issue is right now and how they can maybe service that patient. Most often, they report that most often actually the questions are pharmacy-based. So the pharmacist is very busy answering some of their questions and even making some recommendations on how they may manage their medicines in a different way. Mm-hmm. The other thing they do is they text their patients. If the patient has been hospitalized or had a procedure or had a visit the day before that might have been particularly difficult, they'll text their patients just to check in, ask them how they're doing, ask them about specific questions that they may have had during the visit. Are they comfortable with their regime that they've been prescribed? Is there anything else they can do? Mm-hmm. They use Facebook also, and they also Twitter. And Facebook and Twitter is used just to give the patients access to the most recent information on, let's say, diabetes. Maybe it's a diabetic care regime or facts about diabetes and choosing healthy food. That they use those mediums to be in constant contact with that patient. They feel that it's really important, and they found great results from being in contact with that patient, that the patient never feels that their healthcare providers are distant from them. They have to wait for their next appointment. If they call them, they'll be put on hold. They want immediate access because their patients are living in real life where things happen rather quickly.
Mm-hmm. Well, we're coming up on our last break here. Stay with us. We're going to get to more strategies to reduce hospital readmissions and to your questions as well. So we'll be back in just a few minutes. This is Medicaid Matters, the only live talk show about the business of Medicaid. We're here every other Tuesday, 1 p.m. Eastern, with some of the industry's most enlightening, informative guests, and you'll learn what you need to know to be on top of everything that's going on in Medicaid today. Right now we're talking with Patricia Hines, Dr. Patricia Hines, and Dr. Bonnie Barnt-Maglio, and both vice presidents with the Camden Group, about strategies to reduce hospital readmissions. Well, let's stop here, doctors, for just a moment and summarize. As a result of your research, as a result of your consulting, what have you determined to be the best course of action for both payers and for providers to engage in to reduce readmission rates? And maybe, Patty, you could start off with that.
Well, there's a variety of initiatives. I think the whole notion of the primary care network and having providers available to our patients so that they have the consistency of care in the communities. I think accessing community networks and community resources are very important, and really trying to engage the patient and have them be a partner in the care and understanding what their personal goals are for their health, their lives, their wellness, and meeting them at the level at which they're at. Bonnie, other thoughts?
I think from the hospital perspective, it is broadening the idea of the breadth of their responsibility and the breadth of how to take care of patients. Traditionally, a patient is discharged from the hospital. We take them in a wheelchair to the car, and once they're in the car, that's kind of the end of it. They drive off, and I guess the case management or care management often ends at the boundary of the parking lot of the hospital. We are now beginning to get a much better understanding that our responsibility with care management and our breadth of care management starts before hospitalization, managing them in an ambulatory clinic setting, managing them at home, through the inpatient stay, if need be, and then once they leave the hospital, that follow-up care to make sure that they understand their medications, their care regime, and get the assistance that they need.
We have a couple of questions that have come in from our listeners, and I want to make sure we have time here in the last part of the show to address. The first question is this, and either one of you go ahead and take this one on. How is the health IT reform factoring into the ability to affect hospital readmissions?
Well, I certainly, as we think about the initiatives that are coming forward, I mean, we understand that there is the penalties are being tracked right now for readmissions, and as Bonnie described earlier, we're going to have higher than expected readmission rates. By 2014, those patients that were either unmanaged will have access to health care cards and have access to care. And so those are going to be individuals that were perhaps not as readily available to access care in the past. And so we have this whole new influx of patients that will need to be cared for in a more formal way. And I think that is the opportunity for us then to really think more clearly about managing health and wellness as opposed to episodes of illness and care. And then, again, just as we continue to evolve into the work of bundled payments for care and clinically integrated roles across continuums of health care, we're certainly going to be seeing some of those initiatives.
Mm-hmm. Bonnie, anything to add?
We are lagging behind still with the information system or electronic medical record reform, partly due to the cost. I've worked with several hospitals. The ICD-10 codes are really looming high in their future as how to implement that. We know that's been put off for a while. We don't know when. It was supposed to be October of 2013. So hospitals continue to struggle with the electronic reform, IT reform, and medical record. So in the next 5 years, I think we're going to see a lot of change in that, but also a lot of challenges with that, not just in having an integrated record, but also within an organization, but one that can be accessed for other providers to use in their care and their practice.
Well, this is this next question is kind of interesting. One of our listeners in Michigan has sent this to me over Skype. She's asking, there seems to be a lot of discussion on this topic. Do either of you have a sense that this is a top priority for senior level management in hospitals?
I do. Yes, there is. I think in a recent survey of the American College of Health Executives, 70% said that preventing readmissions is one of their top 3 priorities. It has definitely gotten their attention. Mm-hmm. The CMS reimbursement penalty has very much got their attention, not just from a reimbursement viewpoint, but from the perspective that this is going to be public record. Mm-hmm. So if a hospital has a high readmission rate, it will be something that will be available on the internet, on CMS's website by competitors as well as patients. Wow. So there's high stakes for them, and yes, it is high on their radar screen right now.
I would agree, and I think it's also as senior administrators are working closely with their physician partners and really working on better clinical integration. I think they're really trying to engage medical staff and really also thinking about, again, the wall outside the walls of the hospital and the other areas where care is delivered and needs to be delivered, and how can we best support the patient in their own environment as opposed to the failures that thus require admission. So I do see it as top of mind for senior executives.
Well, we have just a little less than 4 minutes here left, and I wanted to make sure I asked you about this before we closed out the show. So in 2 minutes, if you can, what are some of the challenges and barriers that an organization is likely to encounter in trying to implement some of the things that you've talked about here, just say communications or better profiling of patients when they come in?
So I think that in terms of barriers, we really need to understand our patient population and be focused on where our patients that are at high risk are, and not only the 30 days, but the 14 days, the 7 days. And then we need to risk stratify those patients so we're applying our resources in the appropriate venue. And so I think the notion of we need to have the metrics to know how to manage is real important, and I don't think that we've always got good infrastructure around that. I think there's room for all types of healthcare professionals, whether it's the pharmacist, the social worker, the case manager, the bedside nurse who's dismissing the patient, to really play a role in what we do to manage our discharges. And then I think the barrier is really about understanding what our metrics are and bringing multidisciplinary groups together to create the right strategies that are going to affect our populations and best serve our patients, understanding what their needs are. Mm-hmm.
I think there's also a challenge. We talked a bit about the electronic integrated health record, but there's also a looming shortage of primary care providers. We see a surge towards using providers such as nurse practitioners or physician assistants to support the primary care provider numbers. But if you look at the numbers across medical schools, there is less interest in being a primary care provider. Mm-hmm. And these primary care providers are going to be key, are key, not going to, but are currently keys for us to be able to manage patients on an ongoing basis. So I see that as a barrier and a challenge that we're going to be facing in the next decade.
Well, Dr. Hines, Dr. Barnt-Maglio, I want to thank you very much for joining us here today. I know our listeners are going to come away with a much clearer understanding of this topic, and we can make a copy. We can make a copy of the article available to them. If you've been to MedicaidTalk.com, you've seen some of the things that we have planned. Our next show is on Tuesday, March 27th. The subject will be integrated care management, and our guest is going to be Robert Mendonza, who is CEO of Aetna Better Health in Illinois. Also, I don't want you to forget, go to MedicaidTalk.com right now and register to receive that free best practice webinar from Medicaid Health Plans of America. It's a $150 value. Just sign up for our blog, and we'll have you in the drawing probably for next month. And I hope to see you personally at the Medicaid Health Plans of America Award event on April 30th. We'll be there at the U.S. Chamber of Commerce. We'll be broadcasting live, so make plans to attend if you can. This is your host, Richard Yadon. Today is Tuesday, March 13th, 2012. You've been listening to Medicaid Matters, brought to you by Managed Medicaid Services, and we'll be talking again in 2 weeks. Thanks.